Good evening and welcome to Doctors on Call. I'm Dr. Ruth Westra from the Department of Family Medicine and Community Health at the University of Minnesota Medical School Duluth. Tonight, we'll be taking your questions about upper GI problems like indigestion, heartburn, ulcers, gallstones, even hepatitis. So, what we would like you to do is to learn about abdominal issues. Call the numbers on the bottom of your screen and ask away. Locally, dial 218-788-2844 or call toll-free at 1-877-307-8762. I'm so pleased to welcome our panelists this evening, Dr. Daniel McKee, a gastroenterologist with Northland Gastroenterology Associates, Dr. Jake Prunuske, a family physician with the Lake Superior Community Health Center in Superior and faculty member in the Department of Family Medicine and Community Health at the Medical School Duluth, and Dr. Erin Thackeray, a gastroenterologist with Essentia Health-Duluth Clinic. Our medical student volunteers answering the phones tonight are John Kelsey of Cleveland, Ohio, Karen Knutson from Duluth, and Molly Newstead of Hawley, Minnesota. And now on to tonight's program on upper GI problems. So while we're waiting for the questions to come in, I thought we'd start with Dr. Prunuske and ask about hiatal hernias. Maybe tell us what hiatal hernias are and some symptoms.
Mm-hmm. Sure. So I guess to describe a hiatal hernia, I want to start with a little bit for how we're built. Mm-hmm. So top part of our torso is our chest, which has our lungs. And the bottom part of our torso has our stomach and our intestines. And there's a big muscle that separates the top half from the bottom half called the diaphragm. Mm-hmm. And when we eat, food goes down our esophagus, a food pipe actually goes through that muscle and then into the stomach. And what a hiatal hernia is when that area where the food pipe passes loosens a little bit and the stomach, rather than being below the muscle, kind of slips up through that opening slightly. And the reason that people talk about this or know about it is when that happens, we sometimes get heartburn. And heartburn obviously is a very common problem that a lot of people deal with.
Is there anything that we can do, Dr. McKee, for hiatal hernia symptoms?
Well, there are a lot of things we can do for hiatal hernia symptoms. I guess one thing I would just interject, you can have heartburn without having a hiatal hernia, mm-hmm. and you can have a hiatal hernia without having heartburn or other reflux symptoms. So they don't necessarily go hand in glove. But as far as treating reflux symptoms, whether or not there is a hiatal hernia, you can treat with medications, of course, like acid suppressants, but you can also make lifestyle changes, such as dietary changes, avoiding foods that predispose to reflux, which are things like fatty foods, things with caffeine, alcohol, avoiding tobacco products, chocolate, peppermint and spearmint, onions, any foods that derive from tomatoes. All of those tend to exacerbate reflux. Avoiding large meals and avoiding eating close to bedtime. All of those are issues that can help prevent acid reflux. So those are important things. If you're overweight, losing weight is oftentimes beneficial as well.
Dr. Thackeray, how about elevating the head of the bed? You've heard of doing that also for relief of some symptoms. Does that make any difference?
Yes, it certainly does, especially if they have symptoms at night. So elevating the head of the bed just helps with gravity so that the stomach contents aren't able to come up. And when I say elevating the head of the bed, I don't mean people propping themselves up on pillows, because if they're bending at the waist, they're actually increasing the intra-abdominal pressure and making reflux worse. And so when we say elevating the head of the bed, we mean physically having them sleep at an angle. So putting something like cinder blocks under the headboard, so raising it up about 4 to 6 inches, or sleeping on a foam wedge, which they can buy at a medical supply store.
Good. So there's some relief for patients mm-hmm. with some of those symptoms. Why don't we switch, while we're still waiting for some questions, to ulcers. Dr. McKee, talk about what causes peptic ulcers.
Well, there are a number of things that can cause ulcers, but the two most common underlying causes of ulcers are either a bacterial infection called Helicobacter pylori or medications, specifically pain medicines in the non-steroidal anti-inflammatory class. So that would be things like Motrin, Advil, Aleve, aspirin, things like that. And the combination, having that bacterial infection with chronic use of those types of pain medicines, of course, is even more likely to result in ulcers. So those would be the most common reasons why a person might develop peptic ulcers.
Dr. Prunuske, maybe tell us how we would find out that somebody had H. pylori. We could sort of abbreviate it down to H. pylori.
Sure. Just one more distinction, I guess, is ulcers and heartburn are very different things, and I think sometimes people think of them together, but usually they're separate. And so when people think of heartburn, they talk about acid coming up into the throat or the mouth, but ulcers usually aren't associated with heartburn. In fact, ulcers usually cause pain. So people will get pain in their upper stomach or lower chest. It'll be pretty focal or pointed often. And so sometimes we'll get some clues just by talking to people. We may know that they're taking medicines which make them more likely to get ulcers, or they've had ulcers before. Sometimes people will actually have bleeding, so they can throw up blood or have blood in their stool, in their poop. And so those can be signs that are worrisome for ulcers. In fact, can even be an emergency. So if someone's throwing up blood or pooping blood, it may be a time to call 911 or get to the hospital right away. When it's not quite that emergent, we can find out by looking directly. One of the simplest ways to find out whether or not a person may have an ulcer is to pass a small tube with the camera on it into someone's stomach and look.
And then how would we potentially treat ulcers, Dr. Thackeray? If they're H. pylori, let's start with that one first.
Okay. So to check for H. pylori, we can do it in 3 different ways. So one is there's a blood test looking for antibodies to the Helicobacter pylori. We can do a breath test, which is just looking for a certain compound that the bacteria releases in the stomach. And then there's a stool test that we can do. I guess a 4th way would be doing the upper endoscopy and taking biopsies and seeing the organism on biopsies. And so treatment for the Helicobacter pylori consists of 3 or 4 drugs, usually a couple of antibiotics and some medicines that help block acid. And it's usually taken for about 2 weeks.
Yeah, and the treatments are actually very, very effective. And so, you know, sometimes people treat for a shorter time and sometimes a longer time, but in general, you can get 90% or better of the infections cleared with that treatment regimen alone. So it's quite nice. The biggest challenge, I think, is actually in making the diagnosis. And once you make the diagnosis, treatment is usually pretty straightforward.
Yep, and there can be resistance, and so it's just important that if you do start those medicines that you finish them completely, just because if you don't take all of the medicine, the bacteria can develop resistance, and then we'd have to use other medicines to treat.
Dr. McKee, we're getting some questions now. A question from Two Harbors asking about H2 blockers like ranitidine. Are we okay to take these medications for a long period of time? Are they safe to take, like for GERD or those kind of symptoms?
Yeah, I think as far as prescription medicines go, the H2 blockers or H2 receptor antagonists like ranitidine and Tagamet, there are others, are really quite safe. There's been a little bit more concern over the stronger acid suppressants, the proton pump inhibitors, which would be things like Prilosec. The other name for that is omeprazole. There are others, Protonix, Prevacid. There are 6 or 7 different proton pump inhibitors. The concern there, which I think is a little more of an issue than with the H2 blockers, which aren't quite as strong at suppressing acid, is a couple things. One, in women who are postmenopausal, there is a slight increased risk of osteoporosis when those medicines are used for a very long period of time. So at least in that group, they should be used with calcium and vitamin D supplements if they're going to be used on a long-term basis. There's also some concern in that you're losing the acid barrier, which serves to keep the upper digestive tract sterile. So some issue with potential infection. it's really very uncommon that that occurs, but there are some issues with infections occurring when people are on strong acid suppressants. But overall, those medicines can be used long-term safely, and the risks are relatively low. And so in the proper situation where they really are indicated, for example, in bad acid reflux, it's appropriate.
Thank you. Well, Dr. Thackeray, I have a caller asking about pill endoscopy. Perhaps you can explain what that is and talk about that a little bit.
Sure. What pill endoscopy is it's a pill or capsule that has a camera on one end, and so the patient would swallow it, and we see images. It's mainly used for the small bowel, just because with our endoscopy we can go down so far into the small bowel to visualize, and we can go up so far into the colon, but there's about 30 feet of intestine in between that we don't visualize very well. And so the pill camera is mainly used for that purpose, and it gives us images of the small bowel as the camera is tumbling through, and so it can tell us if there's a bleeding source there or a mass, something like that.
Fascinating. And that's available in Duluth?
That is available in Duluth, yes.
Great. And Dr. Prunuske, a caller asking about incisional hernias. And what do we do about incisional hernias?
So incisional hernias are very different. So this is when someone has an operation or a procedure that makes a cut in the skin and then a cut through the underlying muscle and tissues underneath. And when that incision heals, the healed tissue, the scar, isn't as strong as the original tissue was. And sometimes when we strain, say we lift something really heavy, or we maybe get hit in the stomach, or do something else where the pressure inside of us increases, you can actually push tissue through that healed wound. Now, it doesn't necessarily come out, pop out through the skin like something in the movie Alien, but it can actually be quite uncomfortable for patients, or disturbing because they'll have a mass or a bump on their body that wasn't there. How you address it depends on where it is and sort of the person's underlying health. Sometimes it's perfectly okay to just go on and live the rest of your life with a little bump that doesn't have any impact on a person's quality of life. Other times those incisional hernias can be repaired. Essentially, you reopen the incision, you put everything back where it belongs and close it up.
Excellent. Dr. Thackeray, caller from Duluth asking about the association of pernicious anemia and stomach issues or absorption.
Yep, certainly pernicious anemia is where certain antibodies aren't made, and to absorb iron, vitamin B12, those antibodies are needed. And so certain issues in the stomach can cause pernicious anemia.
Excellent. I got a lot of questions here. Let me kind of wade through a couple of them here. One of the callers, Dr. McKee, just to get back to hiatal hernia again, is asking about surgical corrections for hiatal hernias.
Yeah.
Any comments about that at all?
Well, sometimes it's indicated. Again, like I said earlier, not everyone who has a hiatal hernia even has symptoms from them. But for some folks who have hiatal hernias and have severe problems with acid reflux, either acid reflux that doesn't respond to medical therapy, or perhaps in the situation of a younger person, maybe someone in their 20s, 30s, or 40s, who responds to medical therapy. In other words, they can control their symptoms with medications, but the medicines that we use do not cure reflux, they only treat it. And they look at that and say, look, I'd rather have a one-time surgery rather than continue to take pills for the next 50, 60 years. Having surgery to correct the hernia has a good chance of being a one-time fix. It's a relatively small operation. When it's done by an experienced surgeon, it's really quite safe and has a very high success rate. And I think for folks who are younger, it's certainly a very appropriate thing to consider rather than long-term medical therapy.
Okay. Dr. Prunuske, caller from Duluth asking about gastric cancer with the suggestion that is there an increase in gastric cancer?
So I'm going to defer to my colleagues. Gastric cancer is not my area of expertise. I do know that there are differences around the world in what we see in gastric cancer. And some countries, in particular Japan, have much higher rates of gastric cancer than we have here in the United States. But I don't have the answer to the question. If either of you have more to add, that'd be wonderful.
Have you noticed more of an increase? I think that's the question, and I don't know the answer to that either.
It's actually hugely on the decline.
Right.
Gastric cancer used to be the #1 cancer in this country before there was good refrigeration. I mean, if you went back in the 20s and 30s in this country when people were using ice boxes, gastric cancer was a very, very common cause of death, and it's because we were eating a lot of salted and pickled foods, which basically are carcinogens for the stomach. And with the advent of modern refrigeration and the lack of a need to eat much in the way of those foods, gastric cancer has greatly diminished. And so it's kind of a modern health success story, but not because of physicians so much as because of companies like General Electric.
Excellent.
It's also associated with Helicobacter pylori, and the infection rates have gone down dramatically as well. So that would be another reason for it decreasing.
Yeah, that's great. So, Dr. Thackeray, I'm going to ask a little bit about Barrett's. What are the best options? Someone from Gordon, Wisconsin is calling about best options for treating Barrett's,
Okay.
if there is such a treatment.
Sure. And so what Barrett's esophagus is it's a complication of reflux disease. So when the esophagus is seeing a lot of acid, the cells undergo a change. And in making that change, the patient is at slightly increased risk for esophageal cancer, which is why when we do an upper endoscopy and if we see changes suggestive of Barrett's esophagus, we do biopsies to make that diagnosis. So treatment, really the mainstay is treating the acid reflux, and so that would be with medicines like the proton pump inhibitors or the H2 blockers, and then following the lifestyle modifications that Dr. McKee went over earlier in terms of gastric or gastroesophageal reflux disease.
Well, let's switch topics a little bit here. Talk about celiac disease. Several calls have asked about celiac, how we would diagnose celiac.
So celiac disease is an absorption problem where our body doesn't absorb things we eat as well as they should. And it actually has a very, very wide range of presentations and how this shows up in practice. Sometimes I've made diagnoses in kids as young as 18 months to 2 years old, so young children who come in with they're not growing. I mean, they're not gaining in height, they're not gaining in weight, and we start to look at why aren't they growing and find, oh, it's an absorption problem. There are other cases where people who've lived their whole lives in their 40s, 50s, 60s, and older get diagnosed with milder forms of the condition, and it may just be that they were able to overcome it. There's a blood test, or rather a couple blood tests you can do that can lend clues to the diagnosis, and for confirmation you can actually do a biopsy of the tissue lining the intestinal tract itself to confirm that diagnosis. So when someone suspects, or if someone suspects they may have celiac disease, there are some simple things to do as far as just trying to change dietary patterns. And in general, avoiding things with some wheat proteins. Gluten will minimize or resolve symptoms. If that works, not much more necessarily needs to be done. But if people make that change and symptoms persist, they probably should see their doctor for testing to try to find out whether this is indeed the case or if there's something else going on.
Any follow-up of that? Is there blood tests or anything else that we potentially would do for that, Dr. McKee? Or?
Well, as mentioned, there are a couple blood tests, one in particular that's really quite sensitive and specific for celiac disease. The gold standard is still a small bowel biopsy, but there are good blood tests for it. The tests have to be done when a person is actually on a regular diet, not avoiding gluten, which is found in wheat, rye, and barley. And then when the diagnosis is made, then it requires avoiding those foods with wheat, rye, and barley, and sometimes oats. So, but yeah, there's a good blood test, as at least for an initial screen.
And diet seems to control fairly well, Dr. Thackeray.
Yes. Yep. So, what celiac is it's essentially a gluten allergy. So when you take it in, the body recognizes those proteins as foreign, and it starts to attack the small bowel. And so if you get rid of the precipitating factor, which is the gluten, then that stimulus goes away, and the bowel can heal itself, and absorption can occur again.
Excellent. Well, Dr. Thackeray, just to go back to Barrett's just a moment, there's a caller asking about the correlation between Barrett's and colon polyps. Any association that you know of?
Not that I'm aware of.
I didn't.
I don't know if anyone else has heard of anything, but
I hadn't either, so I just
Okay.
wanted to clarify that. But Dr. McKee, this is an interesting question about ginger on digestion. Any helpful hints about ginger or alternative medications for GERD or that type of thing? That's kind of, I think, where they're going to.
I don't know about ginger. Aloe vera is of some modest benefit, I think, but ginger's a new one to me. I don't know.
There's actually some really solid data looking at the use of ginger for nausea in pregnancy. And so ginger has some anti-nausea properties, and in women who have problems with morning sickness, ginger tea, and other forms of ginger, although maybe not ginger snap cookies, it can be helpful in reducing nausea associated with pregnancy.
Yeah, but I don't think it does anything for reflux.
No, it's not a heartburn medicine.
Or digestion or anything. Yeah.
Mm.
How about, Dr. Thackeray, laryngopharyngeal reflux? Is there anything that would help with that?
And so when we're talking about that, mainly is just saying that reflux is coming up all the way up to the top of the esophagus, and it can affect the vocal cords. People can actually aspirate gastric contents if they're refluxing, and so it's all comes down to treatment of gastric or gastroesophageal reflux disease. So part of it is medicine, but really the mainstay is the lifestyle modification.
Dr. McKee, patients calling about laying on their right side only, they get reflux. Any reason why that would be occurring?
Yeah, well, it has to do with the asymmetry of the shape of the stomach. And so, yes, it does actually make sense. And so some people have reflux lying on one side or the other, and it makes perfect sense, actually. There's nothing unusual about that.
Okay. And Dr. Prunuske, a caller from Hibbing. Now we're going to go to pediatrics a little bit here. 5-year-old frequently vomits after eating. Is there any workup, or what would we be concerned about?
Yeah, 5-year-old, it could be a whole number of things. It's certainly someone who I'd want to have evaluated. At that age, I'm less worried about some of the sort of, sometimes kids are born with funny, things built in funny ways. And at 5, I'm less worried about that. But I do start to worry about the possibility of, could there be an obstruction? Could there be something caught in there? It may be as simple as the child just eating too much and over distending the stomach and then vomiting. There's also a condition called cyclic vomiting syndrome that we don't understand all that well, but has to do with the nervous control of how we digest and how we move things through our digestive tract. And if that system is not working well, people can vomit in relationship to that. But there's a large number of things that could be related to, and with just a small amount of information, couldn't give an answer. It sounds like probably someone who should be seen by a physician for evaluation.
Mm-hmm. Any other suggestions for that?
Yeah, no, I would second that, is that they should be seen for evaluation. Certainly things in 5-year-olds, reflux can sometimes cause vomiting after eating. Certainly we worry about things in the stomach in kids. things like Crohn's disease would be less likely, but it may need, or the child may need an upper endoscopy as a part of evaluation, but they should really see their physician first to get the whole story and find out what's going on.
Good history and physical. Good. Well, thank you very much. I want to thank our panelists, Dr. Daniel McKee, Dr. Jake Prunuske, and Dr. Erin Thackeray, and our medical student volunteers, John Kelsey, Karen Knutson, and Molly Newstead. Please join Dr. Alan Johns next week for a program on lower GI problems, when his panelists will be Dr. Robert Erickson, Dr. Dave Hutchinson, and Dr. Paul Sanford. Thank you for watching. Good night.